our first one for 2026. It is all around respecting choice, reducing fear, and making sense of dignity of risk. And like I was saying, very popular topic, apparently, because this is by far our biggest number of registrations that we've ever had. So do bear with us as Kate monitors the chat somewhere floating around in there, and I continue on with the presentation. Now, if you haven't met us before, welcome, hello. My name's Kathy Kirby. I'm presenting today. I'm a registered nurse and I am one of the directors at Thrive. And floating around, like I said, somewhere is Kate Lamont, who is the co-director at Thrive, and she is a registered occupational therapist. We've both been around a long time and we have had Thrive. We are just going into our 4th year. We love what we do, and what we do is things like this. We run education for teams. We run education like this, free training once a month, and we do training on site as well. We run mentoring programs, and we also do some service support with teams as well. So we'll give you some links at the end of today. So if you want to know more about what we do, you can check them out. But let's get straight into today's session. If everyone could just put yourselves on mute, that would be amazing. Thank you. Some housekeeping, like I was saying, if you could please pop yourselves on mute. We will have time for questions at the end of today. I will stop the recording after the presentation so that you can feel free to talk. Please do pop your questions in the chat though. Like I was saying, Kate will be monitoring that. You will receive a copy of the PDF slides after today, pretty much straight away. Do make good use of the chat. And like I was saying earlier, if you've just jumped in, we are recording this and the link will be uploaded to YouTube. So firstly, like and subscribe, lots of free content on there. And also we want you to, sharing is caring. So share this presentation with your teams, don't reinvent the wheel. That's why we do these sessions, so that you can use them as free training for your teams in your busy schedules. Now today, what are we going to be covering in this short 30-minute session? We are going to be talking about dignity of risk. So what is dignity of risk to start with? We're going to talk about how it links with all the regulatory frameworks. So we're going to talk about where it fits with the Strength and Aged Care Standards, the Aged Care Act, and also the National Healthcare Standards. And we won't be going into detail in these because we are not compliance focused here at Thrive. We are about outcomes, but it is important to know where this fits in within the regulatory frameworks. We're also going to talk about why dignity of risk matters in the first place and supporting dignity of risk in practice, because it is a topic, like I was saying, by far our most registrations. So it is a topic that is front of mind for a lot of us. So yes, we will talk about what it looks like in practice. Now, to get us started, I would like you to use the chat. And I want you to pop in the first word that pops into your head when you hear the term dignity of risk. What is the first word, or what are the thoughts that immediately pop into your head? And I'm going to try and, oh, great, the chat's going. Choice, freedom, options, informed choice, risk-taking, choice and control, freedom, freedom of choice, respecting choice, personal choice, permission to take risk. Choices, wow, everyone said choice. This is amazing.
Just give me a sec.
Respecting choice, empowerment. You know what? This makes me so happy because everything that I'm reading here is really positive language. So I want to give a big clap up front, because when we go out and about, commonly what we hear are some of the challenges that come with dignity of risk. But it is amazing that you guys are all across it. This is all around choice, dignity, risk mitigation has just come up as well. So this is amazing, because this is what the whole purpose of dignity of risk is. It's about living our best lives and doing so in the safest possible way where there is risk involved. Yeah. When we do go out and about and we do training with teams, or we're doing service support, some of the other words that we hear commonly are confusion, fear, danger, risk to ourselves as the provider or the registered clinician around what happens if something goes wrong. Yep. And sometimes this can be what we focus on with dignity of risk. But I'm really happy to see you guys are already thinking about the positives. So we are 2 steps ahead already. Before we get in and talk a little bit more about dignity of risk today, I want to go take a pause here and I want to think about this scenario, okay? So you have your friend Tony, and Tony has told you that he's decided this year he's going to start to ride his push bike to work every day. He tells you that he wants to do this because he wants to improve his fitness, he wants to get outdoors more, and he wants to save money on petrol as well. He also tells you that he hasn't ridden a bike in 30 years. You also know that his workplace is in the city, so lots of traffic around. So my next question to you is this a risky choice? Oh, we've got a no in capitals straight away. Yeah. Yes. Oh, we've got a mix here today. Excuse me. Considered risk. I like this. Yep, I think so. Yes, it will have some risks. Absolutely. So we've got a bit of both ways. Yep. I would say, yes, there is an element of risk to this activity, isn't there? Even though it's something that we might do every day without thinking, there is an element of risk involved. So what are some of the risks that could happen? So Tony could fall off and he could get a minor injury. He could get a major injury. He could get hit by a car. He could get lost on his way to work because there's roadworks. He could get seriously injured, or worse, he might get in, an unfortunate accident and be, killed. So yes, there are definitely risks involved. But what are we going to do next with Tony? Yeah. What are some of the ways that we could be reducing the risk, or Tony could be reducing his risk? Do we want to go all out and say, well, there's all of these risks that we've identified, so I'm never going to ride a push bike again? Or are we going to take steps to minimize the risks that we have identified for Tony, or Tony's identified for himself? And the answer would be, let's start looking at what these risk mitigation strategies might be. And they might be wearing protective equipment. So a well-fitting helmet, wearing the right clothing with that extra layer of protection. So for cycling gear, wearing high visibility colours so that he's seen more easily when he's travelling at night when he finishes work late. Adding lighting to his bike, starting riding around his local area first so that he hasn't been on a bike for 30 years. So let's start small and go around the block or do a few local rides so we get used to riding the bike. And also, do we have to take the shortest route with the most traffic to get to work? Or could we take a slightly longer way where there's less traffic and less risk? Yeah. So is riding the bike still going to be risky for Tony? I can see a couple of nods. Yes, it is. There's still going to be an element of risk involved, isn't there? Yep, but less so, somebody's written in the chat. Exactly, because we've put these minimization strategies in place. We've done as much as we can to reduce that level of risk. And do the risks outweigh the benefit? Is it when you look at the risks and the benefits for Tony, what's more important to him? Tony accepts that there is still going to be that level of risk involved, but he decides that the benefits are going to outweigh those risks. He's going to put these strategies in place, but the benefits to him are that feeling of independence, his health and well-being is really important. He wants to build his confidence up again. He wants to enjoy himself on his way to work and home from work. And he decides that this is all outweighing the risks that have been identified, okay? And this is an example of dignity of risk, okay? So when we have a look at dignity of risk and the term itself, it is not a new term or a concept. It's actually been around since the 70s when it was developed by Robert Persk. And he is inspired after he travelled to Sweden and he saw individuals or adults living with intellectual impairments that were going about not only their daily activities, so the everyday things that we do, but being supported to engage in activities that had risk as well. So that's where the term has actually come from. Now, in here, I've included the definition from the Aged Care Quality and Safety Commission. And we like to bold things to point things out to you here at Thrive. So you will see the keywords that I've identified in this statement here, and bolded in red means they're really important, okay? So when we look at the definition, the concept that all adults, bolded and red, so remember that, have the right to make decisions that affect their lives and to have decisions respected, even if there is some risk, perceived or actual, to themselves. Okay, so again, let's have a look at what is bolded there, and let's start off with what is bolded in red, all adults. Okay, so all adults, now we can all agree adults are aged definitely over 65, aren't they? So if we're caring for older people, that means all of our older people we're providing care for are considered adults. And when we're talking about all adults, we're talking about all adults. It doesn't exclude people living with disabilities, with cognitive impairment, or with dementia diagnosis, okay? So this is where we can start getting that feeling of discomfort, because how can we, in our roles as registered professionals, support a person who has some cognitive impairment or some brain change to make decisions that we might find a little bit uncomfortable or risky? And we're going to talk about that a little bit later today as well. Now, just touching on where these concepts of dignity of risk fits in with the frameworks, and again, not going into a lot of detail, but it is important to understand where it is reflected, because this is what we are governed by when we are registered providers, when we are registered workers for providers. And when we have a look at the strength and, excuse me, aged care standards, excuse me, which came into play November 1 last year, Standard 1 is all about the individual. And if we look at the intent statement, it specifically mentions dignity of risk. And when we have a look at outcome 1.3, I'm going to read this statement out. The provider must support individuals to exercise dignity of risk to achieve their goals and maintain independence and quality of life. It is written there in black and white. It is an expectation that we do this as a part of our role, which is great for us because it can help to relieve some of that stress that we might feel when we are helping somebody make a decision that we might not feel overly comfortable with. It's also included in Standard 3. So again, it says that we must respect people's rights to take risks. And also in Standard 6, which is the new food and nutrition standard. And I know there's a lot of speeches here today, and food and nutrition choices are an area where we definitely know there is a lot of conversation about dignity of risk. Okay, and it is mentioned explicitly there in Standard 6 as well, that we are expected to support people to exercise dignity of risk. Okay, so we are covered, right? If we do the right thing, have the right conversations, we are covered. It is an expectation, actually. Now, when we have a look at the Aged Care Act and the new Statement of Rights and Principles, excuse me again, it doesn't explicitly say dignity of risk, but it is underpinned throughout this whole document, and the Strength and Aged Care Standards form a part of the Aged Care Act. So it is really, dignity of risk is at the core of this entire rights-based framework, okay? So you will have a copy of these slides. You can have a read here, but it is really around supporting people to live active and meaningful lives the way that they choose, and having quality care and services that support those outcomes. So again, it's really supportive of us in our roles as well. Now, national safety and quality healthcare standards. Again, a bit like the Aged Care Act, it is not specifically mentioned as dignity of risk, okay? However, if you look at the national standards, overall, they are focused on embedding person-centered care. Okay, so care that respects and responds to individuals' preferences, needs, and values. And if you look at your Standard 2 here, which is partnering with consumers, it is really around being partners with them to make decisions about their own care. So while it doesn't explicitly talk about dignity of risk, it is really the intent behind all of the standards when you're talking about person-centered care and you're talking about respecting persons' autonomy and choice and decision-making. Okay. So if we're encouraging dignity of risk, excuse me, in these settings, so in healthcare, in aged care, community care, okay, And we started off with lots of positive thoughts when we asked the first question, but we do have some feelings of discomfort and challenges that come with dignity of risk conversations. So, what drives that level of or feeling of discomfort and those feelings that we might find ourselves or we might find with our team members when we are talking about dignity of risk? And it probably comes back to something like this. We're required to provide safe and quality care as well, aren't we? That's our expectation. But how can we do that if the person we're providing care for is undertaking what is considered a risky activity? Okay. This is where it can become a challenge for us. Okay. And this can be a challenge for our team. We might feel quite comfortable with it, but we're not always the ones making the decisions, are we? We have teams who work for us, with us. So it can be a challenge. But what we want to do when we're thinking about these concepts is always go back to the why. And there are a couple of whys that we need to ask before we can get to the how. Okay. And we're going to talk about them now. So, what we want to do is take a pause. Okay. And we want to ask some questions. So, firstly, why is this risky activity important to the person? Because sometimes we can have a black or white, all or nothing kind of approach in our head. But if we can understand the why, then that can help us to have those conversations and get to how we can support the person to more safely undertake that risky activity. Another why that we need to consider is, why is this a risk in the first place? Because is it an actual risk? Because I can tell you, I've had many conversations, many conversations over the 20 plus years I've been around, where people have decided, as caring people that we are, that something is going to be a risk. So we've preempted that something is going to be a risk before it has even happened. So why is it a risk? Is it actually a risk? Okay, these are things that we need to ask ourselves. We also need to ask the person, what is it that they ultimately want to achieve? Because again, sometimes we miss these key points and we think it's that all or nothing, and we miss the bits in between where we can negotiate and we can come up with these risk minimization strategies. And that will help us to get to how can we best support the person to do so. Now, I've got a couple of examples here to talk about what I mean. Now, if we go back to Tony, our friend who wants to ride his push bike to work every day, we ask him, why is this important to you? It is because he wants to improve his overall mental and physical health and his well-being. He wants to improve his quality of life, okay? And he also wants to save money on petrol so that he can travel more. This is all around his quality of life. This is his goals. This is his preferences. This is what is important to Tony. And the risk minimizations, how are we going to support him to do that? Well, he's able to make his own decisions, but he's put those strategies that we spoke about earlier in place to minimize the risk as much as possible. Now I'm going to talk about Jenny, and Jenny is a real case scenario. And this is probably one of these conversations where you start to feel discomfort, okay? Now, Jenny had a terminal cancer diagnosis. She had less than 2 months to live. She was riddled with cancer, unfortunately. In her life before she became sick, she was a chef. Okay. She was assessed by a speechie, and she needed to be assessed as being needing to be nil by mouth. Okay, so the recommendation was not a peg because she was end stage, but a nasogastric tube. And Jenny said, absolutely no way. I don't want a nasogastric tube, because she wanted to be able to taste the food and fluid, even if it was just in very small amounts, because that was her whole life, her whole purpose, her whole adult life. She had been working as a chef around food. She doesn't care if she dies because of consuming that diet, because she's dying anyway. That was her words, okay? So what do we do in this scenario to minimize the risk? Using a teaspoon. I think this is where we can go that all or nothing approach. Jenny didn't want to eat big steaks and big meals every day. She wanted to have that feeling of texture, that taste in her mouth, okay? So she was satisfied with having teaspoons of some modification of the diet when she felt like it, not every 3 meals and 2 snacks, okay? So that was a risk minimization strategy put in place for Jenny. So some other examples of where we could go with the all or nothing approach, but if we took the why and the how approach, we can kind of have a bit of a balance in between. And again, these are based on real life scenarios that I've seen. So we've got Betty, who's been assessed as needing a level 3 and 4 ITSE diet after her assessment. If we were to take the all or nothing approach, which was what was recommended in this scenario a long time ago, it was, okay, well, Betty continues on that regular diet and fluids. She has the dignity of risk conversation. It's written down, signed, ticked, done, put away forever. But when I got involved and had the conversation with Betty, again, it wasn't that she wanted to have 3 meals a day and steak and chips and all of the good stuff. She just wanted her coffee in the morning and her toast. That's all she wanted. She was happy to have the specialized diet at all other times. So the strategies put in for Betty were that she had half a cup of coffee with supervision, and she had the crust cut off her toast. She only had 1 slice, and she otherwise ate the recommended diet. And everybody was happy. We've got Barry, who has had a couple of falls at home. He's ended up in hospital, and he's been assessed as, needing a frame. Barry says, I'm not going home with a frame. I don't want to go home with a frame. I'm not having it. Have a bit more of a conversation. And what are the issues with the frame for Barry? The fact was, he didn't like the look of it. Is that practical? Probably not. But at the end of the day, it was important to Barry. So he was also worried about how he was going to be able to continue to walk his dog if he now had a frame. Those were the 2 things that were important to him, aesthetics and his dog. So by having that conversation and understanding the why and asking those questions, the how became easier because staff found a different frame. It wasn't the perfect frame for him, but at the end of the day, what are we trying to do? We're trying to minimize his risk of falls, aren't we? So he got a different frame. They showed him how to walk safely or more safely with his dog, and he was happy. And finally, we've got Mary with dementia, who's living with dementia. Mary lives at home. She wants to continue cooking her meals, but she's had a couple of episodes where she's left the stove on and she's forgotten the pans on the heat. So the all or nothing approach, again, that was going to happen was Mary stopped from cooking altogether. We're just going to remove everything, remove the pans, turn the stove off, take everything away, and she's going to get Meals on Wheels. Why was cooking important to Mary? Mary has cooked her whole life. She's cooked the same meals her whole life at the same time of day in her kitchen, in her house that she's lived in for the last 55 years. They actually built the house, okay? It is a part of her identity. So what are we going to do to minimize those risks? And we understand the why it's important. So how are we going to minimize these risks for Mary? The meals are planned together. It's the same rotating meals on the same days that Mary generally cooks. They're simple. We implement a stove shut off for her. There are put visual prompts near the stove as well. And where possible, we have staff or family members there to support Mary, not to cook for Mary, just to be around while Mary is cooking and not hovering over her shoulder either, just hovering around in the background, okay? These are the really important points that we need to consider. So do these scenarios, they probably sound familiar because like I'm saying, I could write hundreds of these and they're all pretty similar. Do they remove all the risk? No, they don't. Do they support the person's decision? Yes, they do. Do we still feel a sense of discomfort? Possibly. Yep. Are we 100% comfortable with the decision that our clients have made? Maybe not, maybe. Okay. But I'm sure that in particular, I'm going to run a few minutes over, sorry. I'm sure that Jenny's scenario in particular that I spoke about earlier might make us feel uncomfortable, and that's okay. But what we need to do as well when we're considering dignity of risk is acknowledge where our discomfort is and where our risk tolerance is impacting on what we are doing to support the person. Because sometimes we think something is unsafe or we're uncomfortable with something, and that impacts on how we are going to support the person. So unintentionally, our discomfort is removing the other person's choice. Okay. So the reason that this commonly happens is because we're very much focused on not wanting something to go wrong, and we rather than what could go right. And what we're wanting to do, and what we often don't talk about, and correct me if I'm wrong, and put in the chat if you guys do, is consider the benefits before we look at the risks. Yeah. So when we're looking at supporting some dignity of risk in practice, it's important again to take that pause and consider the risks versus rewards. Okay. So what would happen if we thought about the benefits of engaging in that activity first? Think about all of the positives for Mary if she kept cooking. It's not just about her saying cooking, it's about independence. It's about her eating probably more because it's her own meals. It's about quality of life and feeling satisfaction, getting her up and moving. There's so many benefits that we don't always think about because we're too worried about Betty, I think with Betty or Mary, burning the house down. Okay, so we need to really focus on those benefits first as well and make sure we get them on paper as well as the risks that we're identifying. So when we think about why dignity of risk matters, because we take risks every day. As soon as we open our eyes, as soon as we take our first breath in the morning, we are undertaking risks at some point. And a life without risk isn't really a life at all, is it? Imagine if someone made all our decisions for us and said, no, you can't do that. It's not safe. You can't ride that push bike to work, Tony, because it's just too safe. You might get hit by a car. Removing all risk removes a person's dignity, control, and autonomy. Okay. And what we don't consider when we remove these risks is we think about the short-term benefits of how it will keep the person safer, but what about the long-term impacts? How is it going to affect that person's purpose, their identity, their connection, their confidence? Again, back to Mary with the cooking example. Imagine if Mary had never had to cook again, never had to do dishes again. What's she going to do with her day? Sometimes our decisions might have short-term impact, but we don't think about the long-term impacts either. So Mary's case study was talking about a person living with dementia. And we know that under dignity of risk, we are required, everyone, including people living with dementia, have the right to make choices about how they want to live their life. They also have a right to be included in discussions on how to support them to engage in those risky activities. And that might be by themselves, or that might be with their registered support person or their supporter, because the terminology and the roles have changed, which we're not going to go into today. But some of the questions that come up here are around decision-making capacity. Okay. And this is where it can become complex. And decision-making capacity, again, is not a black and white thing. Just because you have a diagnosis of dementia does not mean that you can never make a decision for yourself again. We all make decisions that people don't agree with. It doesn't mean that we have, we might not be 100% feeling 100%, and we might still make a decision that people think, oh, that's not something I would make. It doesn't matter. That's my personal choice. When we're talking about capacity and decision making, this is an area where we need to do a lot of work, because unless you are in the very advanced stages of dementia, where you are unable to make any decisions for yourself and you've had that assessment, there are many steps before that where you should be supported to make a decision. And only then, after you've gone through all of those questions, risk benefit, conversations, that is when we need to talk about capacity. If you have concern that a person is making a decision that is not in their best interest, it is not aligned with their values, their quality of life, there is, very, very high risk, that is when we need to start talking about capacity. Now, this is an entire topic on itself, and we can't get into that today, but I have got good news in about 3 minutes when I wrap up, because we have got a course coming up around capacity. But it is really important. We cannot just assume, and we cannot decide that because a person has a box ticked that says they have dementia or cognitive impairment, that every decision they make that you don't agree with or you find discomfort with is a risk. Yeah, or something that they shouldn't be deciding to do. So we need to keep that in mind. Now, coming back to the same things, because this is a really important message around dignity of risk. It is not an all or nothing approach. It is not black or white, okay? So these are the questions that we want to do and the approach that we want to do when we are looking at dignity of risk in practice. And it doesn't matter what setting this is. Asking, why does or doesn't the person want to undertake this activity? Start with that. Get to the point, right to the crux of it. Why do they not want to undertake this activity? Why are we considering this activity a risk? Because I can tell you, I've heard some great scenarios and I've thought, I don't understand. I don't even understand how this has come up. It's something that we've created and identified and preempting as a risk, okay? So we need to be careful that we're not doing that. What are the benefits to the person? Let's start with that. Let's start with the positives, like you guys did in the first slide. What are the benefits to the person if they continue with this activity? What are the possible risks? And does the person understand these, including the consequences of what goes wrong? And this is where you start to determine, do we have a challenge with capacity here? Do we need to look further? What is the likelihood of this risk happening? Likelihood as well, because I've heard some rationale that are not really likely to occur. Okay, so what are likelihoods and what are the potential consequences? And then what can we do to reduce the likelihood of that risk or the consequences? And like with those scenarios we talked about earlier, we're not able to eliminate the risk entirely all the time. It might be that we just reduce the likelihood or we minimize the consequences of what's going to happen. But that is ultimately what we want to achieve, okay? So one more scenario as we wrap up, and I'm going to talk to you about Pat. And again, Pat is a real case scenario. Pat lives with dementia and she wants to continue her daily walks around the neighbourhood alone. Staff and family are concerned that Pat may, again, bold capitals, because it hasn't actually happened yet, all right, may become disorientated, forget directions, and take longer to return home. So initially, they consider stopping her from walking altogether, okay? But they didn't, because they're really good. So what they did instead was sit down with Pat and discuss with her, why are these walks important? Okay, what are the benefits to her? What are the risks if Pat continues these walks? And they spoke about them with Pat, because Pat's the person who wants to take the risk, and they put their strategies in place. So she always walks a familiar route anyway. She hasn't deviated yet from that route. She carries ID with her, which has got her address on there. Her neighbours, all the staff. So this lady lived in the community, then she moved to Resi Care. Keep an eye out when she leaves to go for that walk and sort of know roughly what time she goes, roughly to what time she comes back. She's got a mobile phone with her. And when she was in the community, the staff were rostered to attend the house after the time that Pat would have gone for a walk. So if they get to the house and they find Pat's not there, then we know that there's an issue. But if she's there and she's been for a walk, fantastic. The thing that we need to remember is the conversation and the plans need to be documented really clearly, and we need to communicate them with the right people. There's no point writing something down and putting it away for no one to read. If you work in the community, who needs to be aware? The personal carer, the shopper, like all of these people who are providing care for Pat. If you're in the hospital setting, if you're in the Resi Care setting, the admin person at the front desk who sees people come in and out needs to be aware. So we really need to be clear, and we need to make sure we share this information readily with the right people. And this is not a sit and forget and review in 12 months. Okay, if Pat has changes, which she will have probably because she has a diagnosis of dementia, we need to monitor, is this plan working? Is it going well? Are there things that we need to change? If Pat gets lost once, does that mean that Pat can never walk by herself again? No, it doesn't. It means we need to revisit these minimization strategies. What happened this time to lead Pat to get lost? Do we need to implement something else, or was there something else going on, like a delirium, for example? Okay. So let's look at all these factors. So again, you might do all the hard work at the start. You don't want to just throw everything out as soon as something happens, okay? It's about revisiting and having all of those conversations again. So a few minutes over, I'm sorry, but in summary, dignity of risk, concept that all adults, I should have bolded and read that again, all adults have the right to make decisions that affect their lives and to have those decisions respected, whether we think they're right or wrong, or we agree or disagree, or if they make us uncomfortable, even if there is a level of risk, which might be real or perceived, okay? Everyone, including people with dementia and cognitive impairment, have the right to make the choices about how they want to live their life. While dignity of risk is explicitly mentioned in the Strength and Aged Care Standards, but it is aligned very much so within the Aged Care Act and also the national standards. So we have regulatory bodies who are saying to us, this is what we should be doing, okay? Look at the benefits while also looking at the risks, and look at the benefits first. It is not a black and white concept. There are going to be strategies that will work well, that won't work. Some risks are going to be easier to mitigate than others, okay? But again, it comes back to the person's choice, and always ask why. Why is this an issue? Why is it important to the person, so that you can then get to the how. Now, as I wrap up, I spoke earlier about capacity, and you guys have been telling us for a while now that you want to learn more about capacity. So we're very excited that we have got Dr. Anita Paniotu, who is a very experienced clinical neuropsychologist, who is putting together an online, on-demand dignity of risk and capacity program, which will be released in March. It will be facilitated by Anita, so she will be talking like I am now with the presentation, but you will be able to watch it in your own time. Now, when you get your resources from today, you will have a link in there. So if you would like to get an alert when that course is live, then we can send that to you as well. We are also very excited that we have a new online training program, or platform and programs, which is through Open Learning. So we are very happy to say we have got 3 and about to have another 2 courses uploaded. So again, if you are interested, you will head to the link and check these out. But as I wrap up, I know I'm over time. Thank you very much for coming along. We do love feedback. What did you think of today? Did it meet your needs? And what would you like for future sessions? This is literally less than 2 minutes. I think it's 4 questions. So if you could please take the time to fill that in. And otherwise, I'm going to stop the recording now and let you guys ask some questions. I can see the chat has been going off, but I was trying to concentrate. So I will stop the recording, and then Kate can jump off mute and talk about some questions.